Okay, let's speak about COPD or chronic obstructive pulmonary disease. Some of the pathophysiology behind this disorder, it actually includes two different disorders, emphysema and chronic bronchitis. Airway obstruction secondary to emphysema, and that's simply permanent enlargement of the alveoli, or chronic bronchitis, which is that a consistent unrelieved cough. And then those disorders have concurrent inflammatory changes that kind of go along with that. You'll see symptoms related to inflammation of the airways, destruction of the cilia, and then remodeling or changing of those peripheral airways, pulmonary vascular changes that will lead to ineffective gas exchange. We'll see hypersecretion of mucus with these individuals, and then also they'll end up with hyperinflation of the lungs and loss of that pulmonary recoil and alveoli destruction, which causes airflow limitations. Generally, some big risk factors that you see are cigarette smoking or secondary smoke. We may also see this in relation to like occupational chemicals, dust, air pollution, and infections. So those are things we'll want to ask about when we do our patient history. There's also thought to be a genetic component that's associated with that alpha-1 antitrypsin deficiency. We'll see symptoms that increase with aging, but it's not really known if aging itself is a risk factor. And sometimes we'll see this occur along with our asthmatic patients. It is progressive, and we see with these patients constant airway resistance, and it's usually not reversible. Oops, skipped here. So some of our complications that we want to be aware of, we will see that like our patients will end up with hypoxemia. They can have, and sometimes we'll see them hospitalized with the cause COPD exacerbations, to where they actually are admitted because they have low oxygen levels. They may have respiratory acidosis. We may see them come in with respiratory infections such as pneumonia. And then with ongoing progression of this disease, they'll end up with deterioration of the lung capacity, and they can end up with that right-sided heart failure. This is also, so they'll end up with cardiac failure, dysrhythmias, and respiratory failure. We'll also see that these patients often are very depressed and anxious because they have that constant struggle to breathe. So you'll see a lot of discussion in your text about anxiety. So let's talk about some of the things that we want to assess. Again, we already briefly mentioned looking for risk factors such as cigarette smoking, occupational exposure, or any environmental exposures. Assess for cough, exertional dyspnea, sputum production, weight loss. We may have to watch these people over time because a lot of times we'll actually see weight loss with these individuals. Sometimes they'll even end up, in addition to that exertional dyspnea, they'll end up with dyspnea at rest. You want to auscultate breath sounds for wheezing, crackles, prolonged expiration, or even decreased breath sounds. Assess and document any sputum production, and make sure you note like the amount, color, thickness. So see if they're able to actually cough and expectorate that sputum. We may have to actually suction as needed with this. Assess vital signs. You might see tachypnea, cardiac dysrhythmias, low O2 sat. Observe their chest. You'll see with these patients what's called barrel chest due to that enlargement in the respiratory structures. Any use of accessory muscles when breathing, Ask about the best position for breathing. See if they have orthopnea. Ask them about the number of pillows that they use in bed. Look for any changes in level, of consciousness that they may have. Some of our big labs and diagnostic assessment that we'll do, again, we'll see that chest x-ray. It will typically show congestion, hyperinflation, maybe even like a flattening to the diaphragm. We'll do ABGs and look for hypoxemia, hypercapnia, and respiratory acidosis. Our pulmonary function test will look at that forced vital capacity and forced expiratory volume. And we'll typically see lower percentages that equal, decreased pulmonary capacity. Sometimes on our CBC, we'll see polycythemia, and then we'll do sputum cultures to look for any infection, and we'll do sputum culture and sensitivity. So again, as we look at all of our assessment data, we're trying to put the pieces of the puzzle together and think about what problems our patients may have. And so again, through that assessment, we're always looking for, do they have a problem with decreased gas exchange? Do we have any weight loss that might show any nutritional deficits? Anxiety disturbances, decreased endurance, or any potential for infection or pneumonia. And so everything we do with our interventions is going to be around trying to promote good gas exchange and air exchange, preventing weight loss, decreasing anxiety. And so some of the things that we will do, again, oxygen administration, monitoring pulse ox readings on these patients, place them in a position that is optimal for breathing. So that tripod positions, you can use an overbed table or their hands on knees will sometimes help. Administering breathing treatments to help open up and clear the airway, provide antibiotics if there's any signs or problems with infection, encourage small frequent meals and adequate hydration to actually liquefy those secretions so that they can expectorate it. They'll tolerate those small frequent meals better than they will a large meal because that can actually tire them out, cause more dyspnea. We'll try to encourage them to increase activity as tolerated and maybe make small progressions as they're able. And then you might also be teaching them about diaphragmatic or abdominal breathing techniques and pursed lip breathing. This can actually help them exhale some of that excess carbon dioxide that they may have. Home care, we may need to do some education on home oxygen use, the use of any of their medications. The meds are going to be very similar to what we used in asthma. It's going to be more of those long-acting medications and the corticosteroids that are long. You'll also see mucolytics prescribed for these patients well to help them with the expectorating those secretions. So bronchodilators, mucolytics, corticosteroids, and then if there is any infection, they'll have antibiotics for them. And then here is some of the important things to see if our interventions have been effective. And then I also want you to think about some of your education that you might want to do with the patients. We need to encourage them to try to avoid infections, so avoiding crowds. Encourage immunizations like influenza and the pneumococcal vaccine. Now we have the COVID vaccines. These are definitely patients that are going to be more at risk for problems with COVID. Encourage smoking cessation or exposure to secondhand, cigarette smoke. Reinforce good safety measures with home O2 and avoiding any type of environmental exposure to things that might trigger any respiratory problems like dust or environmental exposures that could be allergens. Close the windows, run the air conditioner to avoid any of those external allergens that we may have. Let's look at a few things in the text that I think are good to review. I really did like this box here. It's called Home Considerations, but what I really liked was it did a great job of providing detail of how do you assess for problems with gas exchange. And then you'll see that it gave you some information about, looking at the mucous membranes, the use of accessory muscles. So the clubbing of the fingernails. So it had some great tips for how to assess each area here. All the things that our patients are at risk for. So here's some good assessment techniques for impaired gas exchange, problems with perfusion, altered nutrition, and then understanding of disease adherence. I mentioned clubbing of the nail beds. So here is a good picture of clubbing. And then this patient and family education is a great demonstration of how to teach patients about diaphragmatic or abdominal breathing, which is a different way than we normally believe, but it's using your abdominal muscles to help with respiration. And so here they're showing using a book and how they can push that up and down with inhalation and exhalation. Then we go on to pursed lip breathing, and it's even got, this is where you want to breathe in through your nose and then purse your lips kind of like you're whistling, and exhale. So I thought, if any of you are having kind of problems understanding those two breathing techniques, that's a great kind of little chart. We didn't talk about this with our slides, but typically you're going to see the use of oxygen, the bronchodilators, mucolytics, antibiotics, corticosteroids. So med management, oxygen, nebulizers to treat COPD. But occasionally there may be candidates that do qualify for surgical treatment. And so the two that it talks about are lung transplant and lung volume reduction surgery. And so you'll see that, they're going to have to carefully be screened preoperatively to see who is going to qualify for these. They're typically going to be very end-stage patients, and they've not been responded well to other treatments. They do need to have like a stable cardiac function and be ambulatory, not have other respiratory issues like asthma, cancer, and not be smoking. So they need to be off of all that. To tolerate it, they're going to have to be able to ambulate and tolerate activity. So some patients will not even qualify for surgical treatment. And so that's why we don't see these as often. But I do want to mention it so that you know that there are two surgical treatments that we have for these disorders.